Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, your host, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines in just a little bit, but as a reminder, make sure you're in a quiet room when you call, with your TV turned all the way down so that we can hear your question. Our number is 318-219-4569. It will be on your screen if you forget it. Today's topic is breast health and breast cancer awareness. Joining me today to talk about this is Dr. Karen Berken, OBGYN with Women's Health Associates with Willis, Bossier. Thanks for being here.
You're welcome. Glad to be here.
Absolutely. Yeah, so we're talking Breast Cancer Awareness Month kicks off officially on Tuesday, but it's always a good time to think about, breast cancer and your risk for it. And you mentioned some statistics earlier in our midday newscast, if you want to tell me a little bit more about that, because it's pretty common and it's kind of a scary disease.
Yeah, so what I mentioned earlier is that it's the most common cancer in the United States, and it's actually the second highest or second leading cause of death in the United States cancer-wise. And so it's very prevalent, and it's something that we have good screening tools to detect early and some preventative strategies as well.
Yeah, okay. And we always talk about with cancer specifically, it's best to catch it early or at least prevent it, by screening and things like that. So how important do you think it is to go to your annual appointment with your OBGYN and make sure you're staying up to date on that?
So, I mean, it's obviously I'm a little biased, but it's tremendously important. They kind of used to teach breast self-exams at home, and they kind of found that actually made patients a little bit hypersensitive of different areas and actually caused a little bit more anxiety and harm than good. And so now what we teach is just breast self-awareness. So the appearance, the feel, pain, anything like that, if you notice is different than your normal, then you definitely need to come in and see a provider for that specific issue, but also just coming in annually for clinical exams with your doctor, and then once you're a certain age, starting the standard screening tools is very important.
Right, yeah. And I'm glad you mentioned that about the self-exam. I think that's a pretty common question, a frequently asked question, if you will, for people, like, should I be doing this? And kind of the recommendation really is just that self-awareness. You know your body really well. If it's changing, then maybe let your provider know, but it's not necessarily something that you should worry about when you go home. You just kind of stay up to date with those appointments.
Yeah. No,
Okay.
Absolutely.
Got it. Okay. So recommended screening tools. Mammogram is kind of that gold standard, right? Is it still the #1 preferred screening tool?
So it depends on the age and risk factors as well. So yes, mammogram is automatically what people think of, as far as the standard screening tool. Recommendations for mammograms for the general population that's fairly low risk is to start at age 40. And depending on what source you're using, anywhere from every year to every 2 years after the age of 40 is when a mammogram is recommended. The reason why prior to age 40 we don't necessarily automatically go to mammogram if we need to use some sort of imaging test is radiation exposure in younger patients, but then also the younger someone is, the denser the breast tissue is naturally. And mammography is using X-ray technology. And so if the breast tissue is very dense, sometimes a mammogram can't necessarily see through the tissue very well, so you get this incomplete read on the imaging test. And so for very young patients that come in that have a lump or a painful area or something like that they want examined and evaluated, we typically will start with an ultrasound in the younger patients. But certainly once you're about age 35 to particularly 40 is when mammography becomes better.
Gotcha. Yeah. Well, and I didn't even know that. That's interesting. And especially for young women that may have, like mom or grandma have breast cancer, what's the age recommendation for them?
So the average female, breast cancer, it plagues about 99% of cases are female. There is 1% that's male as well, so it does pertain to our male population as well. But 99% affects females. The average woman with no family history has about a lifetime 12 to 13% risk of breast cancer, which is pretty high when you think about that number. You put 8 females in a room, one of them is going to have breast cancer by the age of 70. And so it's just very, very important to come in and have that screening. And if let's say you come into your doctor and we automatically go through family history. So we're asking other related cancers as well, not just breast cancer. So anyone in your family has had breast cancer, anyone with colon cancer, pancreatic cancer, certain types of melanoma, uterine, ovarian, there's lots of these related cancers. And so we gather all of that information on all of our patients, and particularly the younger someone is diagnosed, or the more cancers that run in the family, the higher risk they become. And so if someone's been diagnosed in the family, and we're talking about first or second degree relatives, but if someone's been diagnosed in the family with breast cancer or colon cancer under the age of 50, that's a big red flag. That's more likely to be genetic. If someone's had more than two or more family members that have been diagnosed with colon cancer, that's a red flag. If someone's had bilateral breast cancer, so they've had it on both sides, not just one side, if there's been any males in the family that have had breast cancer, those are all very high risk for a genetic condition. And then at that point, we would recommend doing a genetic test to see if that person carried a certain myriad of genes that can predispose them quite highly to breast cancer in their lifetime.
Right, yeah. And that's a good point that you kind of distinguish between, okay, there might be a genetic risk, or maybe, let's say, grandma had cancer when she was 70. It might be more lifestyle risk factor, right?
Right, no, absolutely. And if someone has a high family, a high risk of cancer based off of their family history, we use these certain calculation models to give us kind of a lifetime estimate for that person with cancer, even if they don't have a positive genetic test. So even with a strong family history, there's still an increased risk above that 12 to 13%. We typically start to recommend increased screening if their lifetime risk is 20% or higher. It's when we change the screening guidelines a little bit. But if someone has a high family history and we do the genetic test and it turns out they have one of these genes, the two most common ones that people have probably heard of is the BRCA1 and 2. But there's hundreds of others out there. But if someone has one of those genes, then their lifetime risk goes from 12 to 13% all the way up to about 45 to 85% in their lifetime. For cancer. So there's a lot that we need to change for that subset of patients.
Right, yeah, but as you mentioned, most people kind of have that 12 to 13% just
at baseline.
At baseline, wow.
Without any family history whatsoever.
That's pretty crazy. When you said it's the second most common, right,
it's
cancer?
The most common cancer, but it's the second leading cause of death.
Gotcha. Wow. Yeah, something that we don't want to take lightly. Well, if you are just joining us, the phone lines are open, so give us a call, 318-219-4569. It's right there on your screen, and we'd love to hear from you and ask a question to Dr. Berken. We are talking about breast cancer and breast cancer awareness and breast health. So we talked a little bit about self-screening, but let's moving forward, let's say we found someone with early detection, these screening measures. We found someone that has early onset breast cancer, and what are typically some of those symptoms that you would associate with maybe those early stages?
So early stages are going to be pretty subtle. So the advantage of breast cancer a little bit is we often do detect it early. We have good screening tools, and it's fairly easy for someone to notice an issue. And so pain of any kind. Now, some people deal with breast pain that comes cyclically with their period and all of that. So we're not talking about what's their norm, but we hear all the time a patient might roll over in bed and all of a sudden they just feel something that just does not feel quite right, a little twinge or a little pain here or there. Obviously, if there's a palpable mass, then that's concerning. If there's any overlying skin changes, redness, swelling, sometimes you can even see, they call it like an orange peel appearance to the skin of the breast. That's a concerning sign. And then there's lots of connective tissue in the breast, and so if you have retraction of some of those connective tissue structures, you can see dimpling, you can see retraction of the nipple, so there's lots of different signs. Lymph nodes are another one, all the way up into the armpit.
Yeah, I was about to say lymph nodes. Is that like later, would you say, or can that happen in very early stages too?
It can certainly happen in earlier stages as well, but lymph nodes and then metastasis to the rest of the body is obviously a much later stage. It would be stage 4 if they had anything, in the rest of their body.
Yeah, and definitely want to catch it as early as possible. And would you say that these annual screens, like let's say, I don't know if this is even possible, let's say you had your annual, could cancer develop like within that year to where you come back for your annual and it's too late, or how quickly would you say it typically progresses?
So we see quite often where someone will come in, maybe they're 40, it's their very first mammogram, and that one might show maybe not a true cancer, but maybe it shows a preliminary lesion, something that has a high risk of turning into cancer. So they can have that excised before it progresses. But we certainly do see patients that are religious about coming for their screening, and they have their mammogram and their exam every year, and they had a normal mammogram one year and then the next year they have an abnormal. But typically when that does happen, the lesion that's detected on the mammogram is so small that they're stage 1, at most stage 2, which is a lot easier road to recovery and a lot more treatable than stage 3 or 4.
Right, yeah, for sure. Okay, so let's say someone is watching and they're a little apprehensive about going to their annual appointment. Maybe they just turned 40 and they know that this is something that they need to do. Walk me through the process, like what happens during that annual and the mammogram, and is it anything like painful or anything scary to look forward to, or put them at ease?
So, I mean, a lot of people don't love going to get a mammogram. It's not the most comfortable thing. But when you come to see an OBGYN or a primary care doctor, what they do, they should have an intake form. You fill out all of your paperwork. Part of that is the family history. And their doctor will address that with them if there's any red flags there. And then whether they're due for a pap smear or not, certainly every year we do breast exams, so we'll give you a gown. I normally talk to the patient first, then let them get undressed with their gown on, and I'll do a clinical breast exam in the exam room, and then if they're need a pap smear or whatnot, then I'll do the pap smear as well. And I'll go over with them if I feel any areas. If they're new to me, then I'll ask, has this area been here for a while? Does it always cause you discomfort? Does it change throughout the month? Just certain questions like that to just get a little bit more information. If you don't feel anything, then we give them an order to go get their mammogram, just their screening mammogram. If we do feel something, it changes the type of mammogram that we order. If they have a complaint or if we feel something, then typically instead of ordering a screening mammogram, we order a diagnostic mammogram. They are a little bit different.
Okay.
The main difference, they're X-ray images of the breast tissue, but a screening mammogram typically only takes a couple views of each side. And the diagnostic mammogram often takes a lot more images because they're looking very specifically at an area of concern. So they're done very similarly. People are not a huge fan of getting a mammogram. It's incredibly necessary to do, but it is a little bit uncomfortable. They have to position you in a certain way and take these X-ray plates and kind of put them very much up against the tissue, and so a lot of times that causes a little bit of discomfort while they're taking the images because they do have to be on a little bit of pressure.
Yeah, but how long total is the process?
The actual taking of the images is very quick,
Yeah.
just a couple minutes, but the setup takes a little while, and then a lot of breast centers have the ability to review images real time, which is very nice because they'll take an image, and then if there is an area of concern, or sometimes not necessarily even an area of concern, but an area that they cannot visualize very well because of the surrounding dense tissue, then either right then and there or at a very soon, later date, they'll recommend repeat imaging, whether that's taking more pictures at that same visit or getting scheduled for a breast ultrasound. Sometimes even if they see a very concerning area, they'll get you scheduled right away for a biopsy so that they can test the area.
Okay. And so with the dense tissue, we keep talking about that. So how does that impact imaging and looking at the mammograms?
It kind of creates shadows, and it can make it to where you can't see very well across the entire area that you're trying to look at and visualize. And so oftentimes if there's a dense area, then they will read the mammogram as a 0 or incomplete, in which case they recommend some secondary imaging modality to take a look at that area a little bit more closely. So it just kind of obscures the view just a little bit. But there's certainly ways around it, and then having frequent mammograms going every single year is also helpful because the radiologist has all of those prior images to look at, and a general rule of thumb with cancer is if it's not changing, if it's not growing, if it doesn't look more concerning, then it's probably not malignant because cancer typically changes fairly quickly. And so if someone has had a questionable area or a dense area for the past 10 years on all of their mammograms, then you can pretty safely say that that area, if unchanged, is fine.
Okay, yeah, and so and it's more concerning if it's changing over time. And are you looking for like a bundle of cells that look abnormal? That's kind of what you're typically looking for.
A lot of times you're looking for a kind of a well circumscribed area of denser tissue or a little bit of a mass or a nodule. Occasionally you'll see calcifications as well. Cancer tends to have little white specks kind of out all throughout the mass, and that's little microcalcifications, and they can see those very well on X-ray. So that's one of the main things they're looking for. That's a good
thing that they come up, that they show up pretty easily.
Yeah.
Like a buzzer, if you will. So okay, so you mentioned when you're younger, you want to maybe opt for that ultrasound first, and I've heard that maybe it's not as streamlined as maybe mammograms. So, how effective are they? Still pretty effective, would you say, the ultrasounds?
Ultrasounds are still very good. They're very good at distinguishing between cystic breast tissue, which the most common denser breast area in younger patients is just fibrocystic disease, or there can be a more solid component called fibroadenomas that you see. But fibrocystic breast tissue, sometimes there's an actual fluid collection in a cyst wall, and you can distinguish that very clearly from a solid mass on ultrasound, because ultrasound uses ultrasound waves to kind of look at tissue densities. And so if something's fluid filled, it shows up basically black on the image, and if it's more solid or calcified, it shows up as a brighter white color. And so you can distinguish very quickly between those two. And if it appears cystic and the patient's having a lot of pain from it, then a lot of times they do what's called a needle aspiration, where they go in and they just drain that fluid out through a needle. They'll test the fluid, make sure it's normal.
Okay. Yeah, okay, and so let's say somebody finds a lump and then they find out it's benign. I know that from your standpoint, you're kind of getting the awareness, and then maybe from there is someone referred out to like a surgeon to maybe remove that, or do they have the option to just keep it if it's benign?
So if it comes back benign, they basically have both of those options. They can just watch it and wait. And if it ever causes them more pain, or we take a look back at it at a later time and it's changed, then we can at that point kind of push on to a specialist to take a closer look at it. But even if we find something that's benign, if it's bothering the patient, if it's causing them anxiety, and if it's causing them pain, because a lot of benign lesions are painful. They respond to hormones still, and they do cause the patient a good bit of discomfort from time to time. And so most patients that have something, even if it does come back benign, they'll opt to go on, to see a breast surgeon or breast specialist, and they'll just make a small incision over the area, excise the area of concern, and then they won't have to worry or deal with it anymore.
Sometimes it might just be better to have that peace of mind, Okay, so we talk about, 12 to 13% at baseline. You're kind of have this risk for breast cancer. But are there any preventative strategies that we can implement, maybe through lifestyle factors?
So risks associated with breast cancer, so there are certain modifiable risks, and there's some that you just can't change. You're born with them. And so obviously if you can't change your age, you can't change who your family is, where you come from, you can't change your genetics, you can't change how early your period starts. We know that the earlier someone's period starts and the later their period stops, the more at risk they are for breast cancer. And those are things that you have no control over. But certain modifiable risk factors are alcohol use, smoking. We know that patients that have higher BMI have more hormone, typically more estrogen. And so BMI is a modifiable risk factor. If they can drop a little bit of their body fat percentage, then they'll reduce their risk. And then also the number of pregnancies and if they breastfeed or not, that plays into it as well. So really when it comes to a risk factor standpoint, I mentioned early menarche, or when your period starts earlier, or late menopause, those being risk factors, and that's because you just have more years of hormones in your body. And so that is a risk factor. When you're pregnant and when you're breastfeeding, your hormones shift in a favorable direction. So you actually have a reduction in your breast cancer risk because of that hormone shift that happens the whole time you're breastfeeding and the whole time you're pregnant. So
do you mind explaining that hormone shift, like what's happening?
So your estrogen levels typically get pretty low, and your progesterone levels get higher. And so that, along with not having those regular monthly periods during that time frame, contributes to that risk reduction.
But then on the flip side, having more pregnancies can also be a risk factor, like the more you have, or is that?
It's actually the more times you're pregnant, the lower your risk.
Oh, okay. Interesting. So it sounds like a lot of this, maybe like the estrogen is kind of a big, it's like it can be protective in some ways, like our bone density, but then in other ways it can cause, like over time, an increased risk for breast cancer.
It's a double-edged sword,
really
for sure. But the genetics plays a big role as well, because I mentioned the BRCA, or the BRCA1 and 2 gene, that cause a very increased lifetime risk of cancer. If someone knows that they have either one of those genes or several others, but particularly those two, if they know that they have those, we know that being on a hormonal birth control as long as possible is helpful. So if we identify one of those patients, we send them to a breast specialist to follow them and do all of their screening. Oftentimes they'll recommend putting them on a birth control pill or something like that until they're ready to have kids, as a preventative strategy also.
I was about to, go ahead.
I was just it just depends on, there's all sorts of types of breast cancer. Some of them are estrogen and progesterone receptor positive, some aren't. So that's where it gets a little confusing. Some hormones help some but hurt others. Just depending on the type. But in general, if you know that you carry one of those genetic conditions, you'll have a reduction in your lifetime cancer risk. with a birth control pill.
Interesting. So what about for someone that doesn't have those genes? Is hormonal birth control like preventative in any way, or is it not really?
Hormonal birth control, you get into the data is a little bit kind of questionable. You know, when you get into those, it's not necessarily proven to cause harm. But the benefit is not nearly as good as with someone that carries those genes.
Okay, very interesting stuff. I'm learning so much. So, so what about for someone that maybe has had like a reduction or like some kind of like plastic surgery with their breast? Does that affect their screening process?
So typically, no. I mean, they still need screening. There's different types of breast augmentations. There's ways that some tissue is removed. Sometimes the implant's put on top of the muscle. Sometimes it's placed under the muscle. And then certainly with risk reduction, there's some removal of tissue, you know, in that instance. So there's somewhat of a reduction in risk because of that. But then you also do have scars with either type of those procedures. You do have scars that form just naturally from the healing process from the surgery. And those scars are very dense. They can kind of complicate the imaging just a little bit. So when people have had a breast reduction or breast augmentation of any kind, it's very important to go to those regular exams and have those regular mammograms, because a lot of times there are dense areas, but they're looking for change. So it's important to go all the time and have those regular follow-ups so that they can compare year to year.
Yeah, it's kind of, I feel like that's a lot of across the board with cancer. When you monitor it, if it's changing rapidly over time, then that's kind of a concerning issue.
Right.
Okay.
Yeah.
Okay, so let's say someone is not established with an OBGYN. How do they get in contact with you? Are you accepting new patients right now?
Yes, I am accepting new patients. And so to get in touch with us, you can just call our main number, which I believe is on the bottom of the screen, which is 318-212-7931. I'm located in the Willis Bossier main hospital building. It's Suite 240, so it'll be 2400 Hospital Drive, Suite 240.
Right off 220.
Yes, right off of 220. And so they can just call the office and they'll ask for an insurance card and identification when you get there. And basically you can just call and schedule an appointment.
Okay, pretty easy. And annuals are typically free, right? The annuals are for anybody that hasn't maybe gotten established with care. Is that correct? Or
insurance companies they've come a long way with prevention, and so they will, for the most part, cover any preventative services. So pap smears, annual exams, wellness checkups, colonoscopies, mammograms, things like that are screening, that are preventative. Then most plans have that built in to where any preventative services should not have a copay. They should not owe anything out of pocket.
Gotcha. Yeah, and that's really helpful, and it's great to just have that peace of mind, and just it's easy, especially if your insurance does that. Just schedule an appointment, and it's usually not a super financial burden. Okay, so we talked about all of these things, and tell me a little bit more. We have just about 90 seconds left. Tell me what else do you see? You see preventative things, but what else? I mean, OBGYN covers a broad spectrum.
It does, and something that's kind of interesting, a little bit on topic with what we're talking about, is if patients have genetic conditions that predispose them to breast cancer or other cancers, there are actual surgeries that we do to reduce that risk. So I don't do mastectomies, but you can have a double mastectomy or a bilateral mastectomy and almost eliminate completely your risk of breast cancer. Also, we'll recommend once somebody's 35 to 40 or done with having kids, we can go in and we do what's called a risk-reducing BSO, or a bilateral salpingo-oophorectomy, which is taking out tubes or ovaries to reduce risk of lifetime ovarian cancer as well. So there's even beyond screening, there's a lot more aggressive preventative strategies for those patients that have very, very high risk.
Yeah, good to know. Well, and one more time, where are you located? And we have your phone number on the screen if they want to get in touch with you.
Located in Willis and Bossier, which is 2400 Hospital Drive, Suite 240.
All right, thanks for joining us, and this will all be on ktbs.com/podcast.